Thank you for coming here and joining our interview today. The first question, please explain the concept of functional complete revascularization. What is the clinical implication of the functional complete revascularization?
Well, to answer first your last question, the consequence is large. Functional complete revascularization means less people who die, less people who have myocardial infarction, equal functional class, and less redos. What do we mean by it in more detail? Well, standard, classically, revascularization was based upon the angiographic image. If there was a stenosis, a lesion in the coronary artery more than 50%, a stent was placed there. The point is that there are many stenoses, more than 50%, who are not responsible for inducible ischemia. On the other hand, there are also a number of lesions, less than 50%, who do give ischemia. And the most important issue is that prognosis, outcome of patients, is related to ischemia. If a stenosis is giving no ischemia, the patient has no complaints from it, and putting a stent in there only makes things worse, because outcome of a non-ischemic stenosis with good medical therapy is extremely good, less than 1% rate of death or myocardial infarction per year. On the other hand, if a stenosis is responsible for ischemia, if it has a positive FFR, as we say it, then we know that the outcome is worse. If you do not stent it, the rate of death and myocardial infarction is between 5 and 10% per year. If you stent it, you decrease the risk. So the matter is how to select, how to find out which stenoses are causing ischemia and which are not. By functional complete revascularization, we mean that you find that out, and typically in the cath lab we do that by measuring fractional flow reserve, and then we stent those lesions which are responsible for ischemia, and we treat medically those lesions which are not. And by doing that, we have a complete relief of anginal complaints because all the ischemic lesions are stented, but we do not inappropriately increase the risk for the patient by placing stents in places where they are not needed. So in fact, you can say that functional complete revascularization is a refined way of doing PCI.
What is your perspective on the treatment of multivessel coronary disease?
Especially there, this concept becomes important. If you have, for example, a patient with only one single stenosis, which is tight, and the patient has typical complaints of a positive exercise test, well then 1 + 1 is 2, so it is easy to decide that you have to treat that. But in multivessel disease, patients often have multi-lesions, often they are superimposed upon some degree of diffuse disease, and that means that it is not so easy to find out which of the different lesions are causing the ischemia. And all our non-invasive tests are insufficient to do that. And especially if you have diffuse disease, it is also very difficult by anatomic methodology, by IVUS or OCT, to find out where exactly the cause of the ischemia is located. And just in those patients with multiple abnormalities, it is not a question if you have to stent, you should stent somewhere. The question is, where do you have to stent? How many stents do you have to place? And especially in these patients, using fractional flow reserve guides you very nicely exactly to those spots where the patient is benefited by having a stent.
You had a lecture about the SYNTAX trial.
Yes.
So would you explain the differences between the SYNTAX trial and FAME trial?
Yeah. Well, in fact, SYNTAX was a study comparing outcome after bypass surgery versus multivessel PCI. But multivessel PCI and SYNTAX was based upon angiography. So it was, let's say, an old-fashioned way to determine where stents should be placed. In the FAME study, we compared this traditional angiography-guided PCI with FFR-guided PCI. It means that in the FAME trial, first we determined in the stenosis which stenosis were responsible for ischemia, and only those ones were stented. In the control group, we followed the, let's say, old SYNTAX strategy, stenting every lesion which was angiographically significant. And it turned out that by using this refinement, by using FFR guidance, indeed the mortality and the infarction rate could be decreased by 30%, whereas the outcome in patients in terms of complaints or freedom from complaints was different. It was even slightly better in the FFR guided group. Moreover, in the group guided by fractional flow reserve, costs were considerably lower in 98% of the patients. There was less exposure to radiation, less contrast agent used, so in many respects it was better to do this FFR guided PCI.
This FAME trial has changed the practical pattern to FFR guided PCI, and also many studies with FFR are ongoing now. What do you expect the future direction of functional angioplasty with FFR?
Well, I think that in many patients it is a very good way to make PCI a better treatment, and my expectation is that the use of PCI will increase by having these data. Traditionally, you can say, if we are looking at the type of treatments we have for patients with coronary artery disease, you can treat them medically, you can treat them by PCI, you can treat them by CABG. There are indications for each of these three treatments. On the other hand, if one of these treatments, PCI, is made better by refining it, by measuring FFR, it will mean that more patients previously either treated by medical treatment or treated by bypass surgery will come to the PCI group. So I think that the number of patients who are good candidates for PCI will increase. I think this will be the practical consequence. Maybe the number of stents per patient will decrease, but the number of patients done will increase.
Thank you for your good answers today.